ladies and gentlemen, and I want to thank the organizer for inviting me to talk. And I would be talking very briefly about the experience at our own hospital. This is Shaukat Khanum Hospital in Lahore, Pakistan. Lahore is the second largest city of Pakistan and capital of the biggest province, Punjab. Now, this is not a government hospital, and it was built which is the only treats cancer patients. So it is a cancer treating hospital, and it's not government funded. In fact, it was founded in 1992, and since then it is running on donation of the people. So this is the mission, and you note irrespective of the ability of the people to pay, and 80% of the patients who come to the hospital are treated free, and rest of the 20% pay. So that poses a lot of financial burden on the hospital. And one of the ways to, as I said, is by donations, and other half, almost 50% of the budget is generated by the private practice, and in which the laboratory services contribute about 50% of the revenue. So that is why probably it is the only hospital in the world where pathologists is considered more valuable than our clinical colleagues. So very briefly, other speakers have also talked about the type of the cancers in the, and in our country, in female, breast, as it is in the developing world, is the most common cancer. And in the female genital tract, the only difference is that cervical cancer, rather the pre-invasive phase like dysplasia or HPV-associated lesions are seen very uncommonly. Oropharyngeal cancer is very common. And in male, the oropharyngeal comes at the top, and the other tumor. In urinary system, bladder cancer is very common. Prostate is seen, but not as frequently as in the developing world. Now, this is the amount of work we are doing, and we are seeing around 87 to 88,000 surgical specimens every year, and around 15 to 16,000 cytopathology, and most of that is non-gynae cytopathology. We are doing fine needle aspirations and endoscopic ultrasound guided FNACs as well. And in-house FNACs, we do on-site evaluation for every case. And immunochemistry and FISH, we are doing FISH not only in breast but in other as well, and I will show some of the results around. One of the problems which we have noted in is that although we have the technology and we can perform the test, but the ability of the people to pay is restricted. So ordering and getting the test done is not very easy. PCR in other areas. Now, some of the problems which we face is that in order to, as I said, we generate a lot of revenue, and the system the hospital has divided is that we have collection center all over the country where people can deposit their specimens, and they come to a central laboratory in Lahore, and we have another hospital in another city as well. So 20% of what we see is from the hospital, and 80% is from the outside, including review cases. And about the outside cases, what we have, the problem is that we can't, for our own cases, we can go to the computers, we can find the clinical information, our previous reports, our imaging, but for outside patients, none is available, and very limited is provided along with the clinical request form, which poses a great challenge on the time and other of the pathologist. Now, coming to the problems for this work, we have 10 pathologists, including 2 hematopathologists who look after hematology also. One of the conditions of the hospital is that the consultant working there should be either foreign qualified with at least 1 year experience of working in either in UK or in USA, or he should be a local, what we call is a fellow of Pakistan College of Surgeons and Physicians, but at least 1 year experience overseas. So we have 10 consultants doing that amount of work, which is a big challenge. And I will mention digital pathology only in my last slide. So the other problems which we face is that most of us are general histopathologists, and subspecialization, as is seen in the developing countries, is not there in the real sense. Although we have started subspecialization at our hospital, all lymphomas are seen by the hematopathologists only. All soft tissue and bone pathologies are seen only by 2 pathologists, more experienced in that. But mostly it is general pathology. No neuropathologist is available in the whole country. And similarly, only 1 or 2 dermatopathologists exist in the country. Renal pathologists, 1 or 2 in the whole country. And hematopathologists are available, but very few. And I would mention about oral pathology also. We started the subspecialty of oral pathology, I think around 10 years earlier. So we have some oral pathologists, most of them locally trained. Now, I would like to talk a little bit about our training programs, because what I think our effort was to train our own people, mostly in our own country, because that is how the standard of pathology will improve in the country. So we have a College of Physicians and Surgeons like Royal College of Pathologists, but unlike Royal Colleges where they have a separate Royal Colleges for pathology or surgery, we have one college which caters to all specialties, and it is a 4-year training program. We encourage our young people mostly in addition to take the FRC path examination, and in last 8-9 years 5 to 6 people from our hospital have been able to successfully pass the FRC path examination with training in Pakistan and very limited exposure of working in UK. In addition, the universities also produce this MPhil, which is a 2-year training program and only 1 year diagnostic training. And these people are also, qualified to perform cellular pathology, which leads to uneven sort of standards of reporting of pathology, which is a big challenge. Now, certain differences regarding the type of specimen as compared to the developing countries. We see a lot of necrotizing granulomatous inflammations, and we perform acid-fast stain in all those cases. And one of the things I was thinking of digital imaging was that if we, instead of, it depends upon the interest and meticulousness of the individual screening for AFP. I think digital pathology can provide a very good solution to screening of AFP stain slides. Similarly, we see large number of skin cutaneous leishmaniasis, and some of the screening, we don't have any screening program for cancer, no bowel screening program, no cervical screening program, and no mammography screening for breast cancer. So mostly that leads that we don't get early stage tumors in all these areas, and usually larger stage tumors, as mentioned earlier by the speakers. A little bit about our own external quality. We don't have any national local program. We are at a stage where the government is formulating some of the program but not being implemented. We are partially doing with College of American Pathologists, and we have JCI accreditation of the hospital. on individual basis, we are participating in EQ schemes of United Kingdom. So all of the fellows of Royal College working in our hospital, they in their own individual capacity take part in EQ schemes of UK. And again, we send a lot of our cases, not a lot of our cases, some of our cases for second opinion to overseas, and mostly nobody charges us. So it is only a sort of individual arrangements, not really any agreement or something like that. We have some societies. We have a Pakistan Association of Pathologists. We are a member of International Academy of Pathology, and we have a Histopathology and Society of Pakistan, and they hold their annual meetings and try to promote education in pathology. Now, coming back to this is my last slide, and about the digital pathology, we don't have much experience of digital pathology. Several years earlier, at another place, one of the things which really sort of interested me at that stage was hepatitis C is very common in Pakistan, and most of the fibrosis which we measure on microscopes, I came across a paper where they had used digital methods to measure the extent of fibrosis in hepatitis C patients, and we did that. It was a very simple sort of project, measuring the areas using digital, and that was a very. And recently, with the University of Warwick collaboration with Nasir Rajput, we have actually done a work on oral squamous cell carcinoma, which actually we had done earlier using conventional microscopy, tumor infiltrating lymphocytes and pattern of invasion and things like that. But we felt that if it is done with digital microscopy, the results would be better. So these were the only sort of preliminary studies which we had knowledge of digital pathology. Now coming back to what I think about digital pathology and the developing world, and it's very simple. Some speaker in the morning said, this is the third revolution in pathology, and I think he's right. So what I thought was, what we learned from the earlier revolutions was that we successfully started using those things in our routine practice. But how did we do that? First of all, we took part in research studies, and one of the main objectives of participating in those research studies was to learn about those techniques to such an extent that we became confident enough to practice that in our own routine clinical practice. So same, I think, is case with the digital pathology, that we want to learn what digital pathology can offer. Now, I think I cannot tell you what you can offer to us, but what I need to know from you is what you can offer in routine clinical pathology practice. And if those techniques are adopted in the developing world in the routine practice, certainly we will be able to see how they can be useful to us. Some of the things, quantitative method, for example, mitotic counts and grading, someone read about breast cancer. I think those can be utilized or in immunohistochemistry, like Ki67 scoring in different tumors. That consume a lot of time of the pathologist. And in the developing countries, there is a limited number of pathologists. And if digital pathology can reduce the amount of work of a cellular pathologist, certainly we will be benefited from it. Thank you very much.
Thank you very much for that. Any questions? One question.
So, just a quick question. What's the government asking you for sharing the digital images, digital pathology images to the outside or to the international platform, for example? Facebook, Twitter, things like that.
limited extent, mainly for teaching purposes,
Education.
Yeah, as for education they are doing it, or rarely, to get second opinion as well, but that is very limited.